Welcome to the Office of Human Rights training on restrictions, behavioral treatment plans, and restraints. This training is part of the Office of Human Rights statewide training series. The goals of this training are to provide each of you with the knowledge necessary to effectively serve the individuals in your care, considering each individual's health and safety at all times. While each of you are responsible for knowing and complying with the human rights regulations, we want to ensure the process of implementing restrictions, behavioral treatment plans, and restraints is underscored consistently statewide. Additionally, it is important that each of you understand the Office of Human Rights internal processes related to these regulatory mandates. You are strongly encouraged to reach out to your assigned regional advocate when there are questions about the regulations or any of our internal processes. Let's get started. According to the human rights regulations, an individual's dignity and or freedoms of everyday life are considered to be restricted whenever the individual is limited or prevented from freely exercising their rights and privileges. Be mindful, the regulations specifically in 12 Act 35-115-20 mandate that individuals receiving services from licensed providers and providers funded and operated by DBHDS are assured protection to exercise legal, civil, and human rights related to the receipt of the services they are receiving. It is important to note that the regulations do not prevent restrictions from being imposed. However, there are important and necessary considerations needed prior to implementing any restriction. As it relates to dignity or Section 50 of the Human Rights Regulations, providers are not permitted to, quote, partially or totally take away or limit, end quote, an individual's assured rights solely due to the reason they are receiving services. So, for example, mental health, substance use disorder, intellectual disability services, etc. However, should a restriction be necessary for the therapeutic benefit of the individual, the situation and need for a restriction must be assessed and determined by a licensed professional. Now, Section 30 of the Human Rights Regulations defines a licensed professional as a licensed physician, a licensed clinical psychologist, a licensed professional counselor, a licensed clinical social worker, a licensed or certified substance abuse treatment practitioner, or a licensed psychiatric nurse practitioner. Additionally, the continued need for the restriction must be reviewed by the treatment team, which includes the licensed professional each month. The need and or the reasons for the restriction and its continued use must be documented in the individual's services record. Most importantly, the proposed restriction should be discussed with the individual, including the length of the restriction and the criteria for the restriction being removed. The dignity section of the regulations offers procedural context for the implementation of restrictions for 5 areas. So, as we discussed, the need for any restriction of an individual's dignity must first be assessed by a licensed professional. The continuation of the restriction must be reviewed monthly, and the restriction must be reviewed by the human rights advocate and the LHRC prior to implementation. The initial reason or need for the restriction, along with the licensed professional's assessment, must be documented in the individual's services record, along with all subsequent monthly reviews. Also, remember that the individual must be made aware of the proposed restriction and all criteria for length and removal. All individuals receiving services have the right to be called by their preferred name. This speaks to the overall respect and dignity that the human rights regulations assure. However, if the use of the preferred name will result in demonstrable harm or have a significant negative impact on the overall program or the individual's treatment, their progress, or their recovery, a licensed professional may document the need to restrict the use of that individual's preferred name. The next areas are specific to residential and inpatient providers. So, individuals whose religious practices or their attendance at religious services are found to be dangerous to the individual or others, or infringe on the freedoms of others, may be restricted from such practices or services. Individuals also have the right to communicate privately through mail with any person. If a licensed professional makes an assessment that communication with a particular person or persons will result in demonstrable harm to the individual, that individual's ability to communicate with that person can be limited. Likewise, individuals have the right to communicate privately with others via telephone. Similarly, though, if communication with a specific person is assessed by the licensed professional to possibly cause demonstrable harm, access to telephone can be limited. Limiting phone hours and the length of a phone call at a programmatic level can be done, which we'll discuss a little later when we talk about program rules. That's a bit different than what we're talking about now concerning restrictions. Lastly, all individuals have the right to have or refuse visitors. Access to visitors can be restricted or supervised if the licensed professional assesses that visits may result in demonstrable harm to the individual or significantly impact the individual's treatment. Also, should visitors be suspected of bringing contraband or threatening the individual in any way, access to that visitor can be restricted. So, as we are in a global pandemic, there has been modification to the regulations concerning visitation. For your recollection, the Office of Licensing and the Office of Human Rights issued a memo concerning this matter back in March of 2020. Please visit the department's webpage for a copy of this memo and general frequently asked questions related to COVID 19. The website address for DBHDS is www.dbhds.virginia, spelled out, .gov. Now that we have an understanding of restrictions to dignity, we'll explore some mandates for restricting an individual's freedoms of everyday life. Remember, restrictions are allowed, but the process for implementation must be followed. When an individual first enters services until the time of their discharge, the individual is entitled to enjoy all freedoms consistent with their need for services, their protection, the protection of others, and those things that do not interfere with their own services or the services of others. Most importantly, individuals are entitled to receive services that are the least restrictive to their freedom. The list of freedoms that you see here on your screen are found in section 100 of the human rights regulations. So things such as keeping and using personal clothing. Individuals have a right to have and spend their own money. and they have a right to move within the service setting. As it has been discussed, individuals receiving services are entitled to assured rights and to be able to enjoy all freedoms consistent with their needs. Therefore, any and all restrictions imposed on individuals must be justified and carried out according to the human rights regulations. Any restriction to an individual's freedoms of everyday life must be assessed by a qualified professional who has been involved in the individual's care prior to the restriction being imposed. Additionally, that qualified professional must document all possible alternatives to the proposed restriction in the services record. That qualified professional must have determined in advance that the proposed restriction is a necessary factor in effectively treating the individual or is a measure of preventing the individual from being harmed, injured, or succumbing to death. The qualified professional must have documented the specific reasons for the restriction in the services record. And the qualified professional must have explained and provided in writing to the individual the reason for the restriction, the criteria for the restriction being removed, and the individual's right to a fair review as to whether the restriction is permissible. The qualified professional must also regularly review the restriction and ensure the restriction is discontinued when the predetermined criteria has been met. Qualified professionals are those staff qualified by expertise, by their training or education, or their credentials to perform the specific task or line of service. So, for example, QMHP A's or C's, QMHP E's, or QPP MH's. And again, those are just some examples. Court-ordered restrictions are those required by law, must be documented in the individual's services record. Be mindful that restrictions are individually based. Consideration for a restriction must be person-centered. What is experienced as a restriction for one person may be experienced as a support for another individual. What matters is that providers are engaging in conversations with individuals and their treatment teams regularly about preferences and individuals' needs. Remember, providers cannot implement a restriction that is in conflict with the human rights regulations. So, a common question that we often receive is, can a legal guardian override a provider and implement a restriction? So, as individuals receive services from the provider, it is the provider that actually implements the restriction. The guardian has the legal authority to ask the provider to implement a restriction, and the provider is compelled to do so by law, assuming the restriction does not conflict with the individual's human rights and the restriction is carried out according to the processes we've been discussing. While the Office of Human Rights has no regulation over legal guardians, we do, however, regulate you, our licensed providers. Therefore, providers must follow the process as outlined by the human rights regulations regarding the implementing of restrictions. A key responsibility of the Office of Human Rights is the role we have in facilitating this type of due process as a means of ensuring the rights and protecting the freedoms of individuals in our service delivery system. The Human Rights Regulations covers the implementation of restrictions in two sections. We've talked about dignity or 12-35-115-50 and restrictions on freedoms of everyday life or 12-35-115-100. Specifically in section 100, subsection B, as in boy, 5, providers are required to obtain approval of the LHRC for any restriction imposed under sections 100 or 50 that lasts longer than 7 days or is imposed 3 or more times during a 30-day period. Think of this as the frequency duration threshold. To assist the provider in detailing the restrictions for the Office of Human Rights and the local Human Rights Committee, the provider must complete the LHRC review form. That form is titled Restrictions to Dignity and Freedoms of Everyday Life. And we'll review this form in just a little bit. Completion of the review form is a requirement and must be correctly completed prior to coming before the LHRC. Upon review of the restrictions, the LHRC will provide recommendations regarding the implementation of the restriction as it relates to compliance with the human rights regulations, should there be any. The provider is responsible for adhering to the recommendations and providing updates to the LHRC. We in the Office of Human Rights acknowledge your experience and expertise. So it is not our role, or not the role, rather, of the LHRC to determine whether a restriction is necessary, but to identify whether the restriction is being implemented in accordance with the processes outlined in the human rights regulations. LHRC review of the restrictions may occur after the implementation of the restrictions. However, all restrictions should be discussed with the individual prior to implementation. Moreover, and most importantly, your Office of Human Rights advocate must be informed of the restrictions to dignity, and the reasons for the proposed implementation must be made to the advocate prior to implementation. Should LHRC review occur after implementation of the restrictions, the provider must ensure the restriction is justified and carried out according to sections 50 and or 100 of the human rights regulations. As a reminder, restrictions to dignity are assured rights and are specific. These restrictions under Section 50 of the Human Rights Regulations require a specific process to implement. Restrictions to freedoms of everyday life, which are found in Section 100 of the Human Rights Regulations, are more broad, but still require a process to implement. Please make sure to review each section of the review form and answer all questions accurately and completely. If a question requires some sort of additional documentation, assure that the appropriate documentation is submitted with the review form. You may follow up with your assigned regional advocate for instructions on how, where, and when to submit this review form. As you'll see, the restrictions review form covers sections 50 and 100. The form is aligned with all of the information we've just discussed. While every question and answer on this form is important, you must give careful consideration to the list all restrictions section, which is here at the bottom of the form. This section should be clear and concise. You must also be able to document and explain all of the less restrictive measures attempted prior to the decision of the licensed professional or qualified professional to impose a restriction. Before moving on to behavioral treatment plans, let's explore the meaning and purpose of program rules. What is significant to understand about program rules is that they are standards of conduct for all individuals within the program. The rules or expectations should be developed to outline how individuals should behave and interact with each other to maintain order and safety within the program setting. The rules also allow for consequences when rules are broken. So, as a note, consequences should be commensurate to the specific infraction. Each individual must be given a copy of the program rules in a manner that they can best understand. The rules can also be part of your organization's internal policies. In developing and enforcing the program rules, providers must be careful not to include rules or expectations that are in conflict with the human rights regulations or in conflict with any individual's ISP. Additionally, the rules should only be developed to maintain safety and order. The regulations also outline what the provider must do in developing these rules, such as involving all individuals who are expected to follow the rules in the creation of the rules, enforcing the rules the same way to each individual, providing the rules to each individual and their AR if applicable, including an explanation of consequences, posting the rules in summary form in all areas regularly accessed by individuals and their families, submitting the rules to the LHRC for review upon request by the advocate or LHRC, and ensuring individuals are not responsible for disciplining their peers unless some sort of self government program has been approved by the LHRC prior to implementation and included in your internal policies and procedures. Specific to home and community based services providers, we acknowledge the potential conflict when attempting to comply with requirements and regulations, particularly related to visitation. Please contact your assigned regional advocate and your DMAS contact responsible for conducting your policy review with any questions or concerns on this matter. You are encouraged to rely on processes for the use of individualized restrictions as opposed to program rules for these potential conflicts. A behavioral treatment plan, or BTP, is a positive tool and resource to assist the individual in reaching their therapeutic goals. The BTP must be carefully developed based on systematic data collection by a licensed professional or licensed behavior analyst. After the period of data collection, the BTP must include documented procedures for how the plan is to be carried out. The documented procedures are integral to the ISP. They're an integral part of the ISP. So, in other words, the procedures are essential to the ISP. The human rights regulations allow for providers to use individualized restrictions like restraint and timeout in a behavioral treatment plan. These restrictive interventions should only be used in a BTP to address challenging behaviors that present an immediate danger to the individual or others. Most importantly, as we just discussed, the BTP can only be implemented after a licensed professional or a licensed behavior analyst has conducted a detailed and systematic assessment of the behavior and the situations in which it occurs. We discussed earlier the credentials necessary to be considered a licensed professional. A licensed behavior analyst is a person licensed by the Board of Medicine to practice behavior analysis. Either a board certified analyst or BCBA or board certified assistant behavior analyst can become a licensed behavior analyst. The licensed professional or licensed behavior analyst is required to conduct the assessment, although they are not required to also write the plan. A qualified professional can develop and implement a restrictive plan, assuming a licensed professional or licensed behavior analyst has conducted that systematic assessment. An independent review committee is appointed or accessed by a provider to review and approve the clinical efficacy of the provider's behavioral treatment plans and associated data collection procedures. An independent review committee shall be composed of professionals with training and experience in behavior analysis and interventions who are not involved in the development of the plan or directly providing services to the individual. Please note that the Office of Human Rights does not have oversight authority or responsibility for the Independent Review Committee or IRC. While it may be best practice, only BTPs that contain restraint or timeout require the higher standard of a detailed and systematic assessment by a licensed professional. Keep in mind that all restraints identified in the BTP must align with the provider's behavior management program protocol. So, in other words, TOVA, MANT, etc. If a physical intervention is needed to maintain an individual's safety prior to the IRC and or LHRC review, providers may use their emergency response policies and procedures. Providers that are ICF or IID facilities must submit behavioral treatment plans involving restraint or timeout, along with its independent review committee approval, to the specially constituted committee or SCC. All other providers must submit BTPs involving restraint or timeout, along with their independent review committee approval, to the LHRC prior to implementation. A very important note: seclusion is not allowed as part of any BTP. As with the restrictions review form, make sure to review each section of the BTP review form and answer all questions accurately and completely. If a question requires some sort of additional documentation, ensure that the appropriate documentation is submitted with the review form. You may follow up with your assigned regional advocate for instructions on how, where, and when to submit the review form. Again, as stated previously regarding the restrictions form, be sure to complete this section clearly and completely. You must also be able to document and explain all of the less restrictive measures attempted, all restraint or timeout procedures, including the type and parameters for use, and lastly, the page number where the intervention can be found in the BTP. So let's move on to the use of seclusion, restraint, and timeout, which is section 110 of the Human Rights Regulations. First, let's break down some of these terms. Importantly, only those providers licensed as a children's residential facility or an inpatient hospital or DBHDS operated facility may use seclusion. Even then, though, these providers must have approved policies prior to the use of seclusion. You'll see that seclusion is an involuntary process. This simply means that the individual did not have a choice in whether they were secluded. Furthermore, an individual is considered to be secluded when they are placed alone in an area that is secured by a locked door or a door that is held shut or by a staff person physically blocking the door or by another physical or verbal means causing the individual not to be able to leave. Similar to seclusion, timeout is involuntary. It stipulates that a staff person remove an individual from a situation that the individual is involved in to remedy some maladaptive behavior. Specifically, to constitute timeout, the individual would be removed to a different open location for a predetermined amount of time. However, if the individual's behavior subsides prior to the predetermined time frame, the individual may be allowed to re-engage before time expires. The definition of timeout implies that it is a procedure that should occur within the context of a planned intervention. The appropriate use of restraints are those which use a mechanical device, medication, or physical intervention to prevent behavior that places an individual at imminent risk. There are three types of restraint listed, and we'll take the next few minutes to review each of those. There are times when an individual may need certain supports to increase their functioning. For circumstances such as this, and when the individual voluntarily chooses to use the support or protective equipment, the use of the support or protective equipment is not considered to be a restraint. The provider must discuss with the individual and their AR, if applicable, at the time of admission, the individual's preferred interventions, those interventions that have worked for them previously. Any known contraindications, including medical or history of trauma, to the use of any form of physical or mechanical restraint must be documented in the individual services record. Any such indications should be documented for the use of seclusion and timeout. Restraints and also seclusion and timeout cannot be used as a form of punishment. No staff may use a restraint that places the individual in a face down or prone position. It is important to remember that all individuals receiving services are entitled to be completely free from any unnecessary use of restraint or seclusion or timeout. Be sure that all less restrictive measures have been explored and documented before the use of any restraint for a behavioral, medical, or protective purpose. As a note and friendly reminder, all restraints and seclusion must be reported annually to the Office of Human Rights by January the 15th. Any questions you have regarding that mandate, you may get in touch with your assigned regional advocate. Physicians cannot have standing orders for the use of any restraint. Again, physicians cannot have standing orders for the use of any restraint. Physicians must prescribe restraints specific to an individual. As shared a bit earlier, there are three types of restraints. Again, they are mechanical, pharmacological, and physical. Mechanical restraint is when a provider uses a mechanical device that cannot be removed by the individual to restrict their freedom of movement or functioning of a limb or a portion of their body to avoid or prevent imminent risk. If the use of a mechanical device is voluntary, if it can be removed by the individual, and used for a protective purpose, it is not considered a restraint. We'll discuss in more detail the different purposes of restraints, but for the sake of explanation, examples of mechanical devices include things like seat belts, helmets, and arm splints. Note that the LHRC does not need to review mechanical devices that are used for protective purposes, namely that a doctor has prescribed and an AR has agreed to the use. Providers are still required, though, to have documentation demonstrating compliance with Section 100B3A through E, indicating things like involvement by a qualified professional, the reason for the use of the device, and that least restrictive interventions have been tried. Again, that can be found in Section 100B as in boy, 3A through E. A pharmacological restraint is the use of a medication administered involuntarily for the emergency control of an individual's behavior, when that behavior places him or others at imminent risk and the administered medication is not a standard treatment for the individual's medical or psychiatric condition. These are often referred to as PRNs, as needed medications. Providers should be aware that individuals who lack capacity may be compliant when offered medication, but in order to be voluntarily administered, an individual must have capacity to provide informed consent for psychotropic medications. If providers utilize pharmacological restraint, they must have a restraint policy to specifically include pharmacological restraint. Best practice is to have a doctor's order with instructions and criteria for use and discontinuation. This may require you as the provider to work more closely with the prescribing physician. Pharmacological restraints are not typically included in BTPs as BCBA providers are not the prescribing entity. Therefore, the LHRC does not typically review pharmacological restraints. Providers are asked to review pharmacological restraint use with the advocate to ensure that the use is operationalized specific to the individual. For example, as needed and when agitated are not specific enough to prevent potential abuse. Parameters such as when agitated as demonstrated by 10 minutes of loud vocalizations or 15 minutes of pacing behavior provide better guidance for use. Physical restraint, also referred to as manual holds, means the use of a physical intervention or hands on hold to prevent an individual from moving their body when that behavior places him or others at imminent risk. It is important to note that imminent risk does not include mere noncompliance or property destruction in itself. And when the imminent risk is gone, the restraint should be released. Providers should have behavioral intervention policies that address specific protocols and staff training related to when, how, and why you use physical restraint. In addition, providers should pay special attention to the use of, quote, physical escort or other terms that may be inconsistent with the form of behavior intervention technique addressed in your policy. In some instances, physical escort does not meet criteria for restraint, and in other instances, it does. Staff should be mindful of any time they seek to physically engage an individual. If it is for behavioral purposes, to control or restrict movement of a body part, it is a physical restraint and must meet imminent risk criteria. So now that we've talked about the three different types of restraints, we'll now talk about the three different purposes or reasons for restraint. When reviewing what the purpose of a restraint is, behavioral, medical, or protective, we start by looking through the lens of behavior and move from there. Restraints for behavioral purposes means using any of the three types of restraint to control behavior or involuntarily restrict freedom of movement when there is an emergency, non-physical interventions are not viable, and safety issues require an immediate response. Note that Section 60B(5) of the Human Rights Regulations require that, quote, providers shall not deliver any service to an individual without an ISP that is tailored specifically to the needs and express preferences of the individual, and services provided in response to emergencies or crises shall be deemed part of the ISP and thereafter documented in the ISP, end quote. In other words, once an emergency restraint has been required, the potential need moving forward should be reflected in the service plan with all the required protections we have previously discussed. The support team will likely need to meet, reflect, and document justifications for next steps. In short, emergencies are not a free pass for hands-on interventions. Rather, emergencies require follow-up processes to ensure that proper protections are in place for the individual. Restraints that will be necessary on an ongoing basis will need to be detailed in a behavior treatment plan, and the process and requirements for the development of a behavioral treatment plan must be followed. Remember that continued demonstration of behaviors that require an emergency response at some point are no longer an emergency, but a pattern of behavior that places the person at imminent risk and must be addressed through the use of a behavioral treatment plan. Ultimately, providers should have policies for use of restraint that includes procedures for emergencies, staff training, as well as how they track or document and report instances of restraint. Restraints for medical purposes means using any of the three types of restraint to limit the mobility of an individual for medical, diagnostic, or surgical purposes when use of the restraint is not the accepted clinical practice for treating the individual's condition. Medical devices typically require a doctor's order as the licensed professional and informed consent. LHRC review is not required. As always, however, documentation of the required protections as outlined in 100B3 A through E should be in the record. So, in other words, the reason, the least restrictive justification, limits on use, and written documentation. Also, be reminded that advocates have the authority to conduct independent investigations, request additional information for their own review, or an LHRC review as needed. The purpose of a human rights investigation or review in this situation would always be to ensure due process of these regulations. By way of example, using a lap belt for an individual that does not typically use a lap belt for body positioning in order to keep them still for an eye exam is a form of restraint for medical purposes. Another example would be sedation medication for routine care or procedures related to post procedure care processes. Restraints for medical purposes are very targeted and are related to specific medical procedures. Restraints for protective purposes means using a mechanical device to compensate for a physical or cognitive deficit when the individual does not have the option to remove the device. The device may limit an individual's movement, for example, bed rails or a jury chair, and prevent possible harm to the individual, or it may create a passive barrier, such as a helmet or gloves used specifically to protect the individual. Remember, voluntary use of protective equipment is not considered a restraint and does not require LHRC review. However, the use of a restraint for protective purposes must be detailed in the individual services record, which will be reviewed annually by the treatment team to include review by the individual and AR if applicable. An example situation would be when an individual puts his helmet on before he bangs his head and then takes it off when he is finished. If there's an individual that bangs his head and the provider must put the helmet on and the individual cannot take it off on their own, that would be a restraint, albeit for protective purposes. As with restraints for medical purposes, providers must have a conversation with the advocate to agree that the mechanical restraint is used for behavioral purposes or protective purposes. A restraint that is protecting someone from an injury due to behavior is not a restraint for protective purposes, but for behavioral purposes, because it is the behavior that requires the use of the restraint. Finally, not all restraints require LHRC approval, but any restraint, whether physical, medical, or pharmacological, included in a behavioral treatment plan is subject to LHRC approval after the IRC approval prior to implementation. Not all restraints require a report in CRIS. Providers should only report improper uses of restraint and restraint resulting in an allegation of abuse or neglect or complaint in CRIS. However, if you as a provider have a question about whether or not the restraint was proper and you are investigating, this goes into CRIS for our office to monitor. Any use of restraint with injury must always be entered into CRIS to evaluate proper use and force of restraint. Section 230 of the Human Rights Regulations does spell out requirements for collection and provision of a provider's restraint data annually. This consists of information about each instance of restraint, whether for behavioral, medical, or protective purposes, including the duration, the purpose or rationale, and the type of restraint. Remember, this information is due annually to the Office of Human Rights by January the 15th. Please contact your assigned regional advocate should you have any questions about that regulatory mandate. Thank you for attending this training presentation on restrictions, behavioral treatment plans, and restraints. And on behalf of my colleagues and peers here in the Office of Human Rights, thank you as always for the hard work that you do in caring for the individuals in our service delivery system.